Thank you, Chairperson, for your kind introduction. I'm Chang from Seoul National University Hospital. I got research grant related to this lecture. Oh, it works. Yeah, thank you. Yeah, this is the outline of my talk. First, I'll explain why hepatic steatosis and iron overload are important. Then I'll review quantification methods for liver fat and iron respectively. Lastly, I'll give a brief summary. Yeah. The liver is very important for fat metabolism. Hepatic steatosis is defined as an excessive accumulation of lipids within hepatocytes. When hepatic steatosis occurs without any secondary cause, it is diagnosed as non-alcoholic fatty liver disease. Wait a minute. Roughly affect over 1 billion people worldwide, and if left untreated, can lead to advanced fibrosis, cirrhosis, and even hepatocellular carcinoma. Early stage of NAFLD is a reversible process. So early detection and adequate management of NAFLD is important to prevent its progression into more advanced stages. That is, evaluation of hepatic steatosis is very important. Let's move on to iron overload. The liver is the main iron storage organ and the first to show iron overload. Iron overload in the liver causes toxic reactive oxygen species, which damage liver cells. As in the case of fatty liver, the iron-driven damage of hepatocytes leads to hepatic fibrosis, micronodular cirrhosis, and hepatocellular carcinoma. Iron overload can broadly be classified into two types. The first type, primary iron overload, is a genetic condition where there is a defect in the hepcidin or hepcidin-related proteins, leading to excessive iron absorption. And the second type is secondary iron overload, is caused by by factors such as repeated blood transfusions, frequent iron injection, or liver disease. Although the distribution of iron deposit may differ based on the underlying cause, the liver is always involved in iron overload regardless of the cause. Then, how do we assess hepatic steatosis in an iron overload? Liver biopsy has been gold standard for diagnosing hepatic steatosis and iron overload. However, liver biopsy has several limitations, including invasiveness, small sample size, inconsistent distribution of samples, and a high degree of variability in interpretation among readers or within a single observer. Excuse me. Thank you for understanding. Yeah. Due to these limitations, there is a need for non-invasive method to assess hepatic steatosis and iron overload. Okay. Next, let's discuss the quantification method of the real fat. Before diving into fat quantification, I would like to bring to your attention a seminar paper by Dr. W. Thomas Dixon, published in Radiology 1984. This paper marked the beginning of the history of real effect quantification by firstly introducing the concept of in-phase and opposite phase. When exposed to an external magnetic field, photons in water molecules resonate slightly faster than photons in fat molecules. A chemical shift refers to the small variation in the resonance frequency of a nucleus in a molecule due to its local chemical environment. The average chemical shift difference between fat and water is about 3.5 ppm. So the resultant frequency difference at 1.5 Tesla is about 220 hertz, and the period is about 4.4 milliseconds. At 3 Tesla, the chemical shift doubles while the oscillating period halves. The two-point Dixon technique is a commonly used method for detecting river fat. It involves acquiring two gradient echoes, one at TE, in which the water and fat signals are in opposite direction, referred to as opposite direction, opposite phase image, and one at TE, in which the two signals are in the same direction, referred to as the in phase. Typically, the two-point Dixon techniques follows a magnitude-based approach with the following assumptions. The magnitude of the signal in opposite phase is the absolute value of the difference between the water signal and the fat signal. And the magnitude of the signal in phase is the absolute value of the sum of the two signals. By combining them, we can calculate the intensity of water signals and the fat signals. And the fat fraction can be calculated just by looking at the intensity of the signal in phase and the signal in opposite phase. This equation is applied on a pixel by pixel basis to generate a fat fraction map, which can be displayed in grayscale or color. To obtain the final fat fraction value, we draw a region of interest on the fat fraction map and calculate the average fat fraction within that region. However, the fat fraction obtained by this method is not the true value. There are multiple confounders and they should be addressed in order to make accurate estimates of fat fraction. The first one is T1 bias. T1 bias results from short T1 of fat compared to water that raises the relative amplification of fat signal. Use of a low flip angle is a commonly used strategy. As shown in this figure, reducing T1 weighting by decreasing flip angle can minimize T1 bias. Since the in-phase signal is usually received after the opposite phase, the signal in the in-phase will be relatively smaller, leading to underestimation of fat fraction. T2 star decay effects are minimized by incorporating T2 star into the signal model. To complete the T2 star decay correction, additional echoes should be needed. This is an example of a patient with concomitant iron overload and hepatic steatosis, showing a fat fraction maps generated without and with T2 star correction. The T2 uncorrected fat fraction values are underestimated. Previously, we assumed that fat has a single peak with a 3.5 ppm chemical shift from the water signal, but it's not true. Water has two photons in a molecule located symmetrically to each other, but fat has more photons in a molecule, and their location is different from each other. So they had a different extent of shielding impacts and resulted in multiple peaks. Sorry about that. It works, okay. Ignoring the complexity of a fat spectrum would result in the underestimation of fat. By applying multi-peak spectral modeling, the accuracy of the fat fraction measurement can be improved. The R-square and slope of MRI PDFF are increased to near 1, which indicates a nearly perfect fast correlation with MR spectroscopy. This correction leads to an increase in the PDFF value, 24% to 30%, reflecting a correction of the previous underestimation. By using multi-spectral modeling and T2 corrections, the accuracy of fat fraction in detecting steatosis was significantly improved and became near perfect. There are other biases, including noise bias and eddy currents. Because of the time constraint, I would skip these two confounders. Removing multiple confounders, including T1 bias, T2 decay, and spectral complexities, we finally get the real fat fraction, so-called proton density fat fraction, PDFF. Now we will move on to the two different approaches in calculation of fat fraction. There are two main approaches. One uses magnitude data only, and the other retains both magnitude and phase information. A complex-based approach has a strong point in image acquisition and wide range of quantification, but a substantial proportion of sites participating in clinical trials or in the next few years are unlikely to have access to these advanced sequences. So until now, therefore, most clinical trials have used the magnitude-based MRI PDFF. Fat fraction maps can be calculated on a pixel-by-pixel basis and displayed in grayscale or in color again. However, it should be noted that the dynamic range of fat fraction from this magnitude-based method is limited to 50%. This restricted dynamic range occurs because only magnitude of the difference between fat and water photons are considered. Resolving this problem requires additional information such as phase information or methods that acquire additional images and exploit differences between water and fat T1. Now we will focus on the complex-based approaches. It uses both magnitude and phase information from image acquired at times appropriate for separation of water and fat signals. Phase shift results from three main sources: measurement and removal of the magnetic field inhomogeneity from the signal permit unambiguous water fat signal separation, and overall measurement of the fat fraction over a full range of 0 to 100%. The separate water and fat images are color registered and can be recombined into a fat fraction map. And this is the process of generating fat fraction map by using the complex-based approach. From the separate water-only and fat-only images, fat fraction maps with the full dynamic range can be calculated finally. Analysis of the PDFF map is an area of active investigation, and there is currently no consensus on how to measure PDFF. Generally, it is recommended to place multiple large RYs at representative region in the river, avoiding large vessels, viaducts, and river regions. In terms of diagnosis performance, as we all know, MRI PDFF has a nearly perfect diagnosis accuracy for detecting hepatic steatosis. It can also well differentiate mild or lesser hepatic steatosis and moderate or greater hepatosteatosis. Linearity was excellent within a minimal bias, and MRI PDFF has been reported to have a high precision across scanner platform, manufacturer, imaging centers, and field strengths. The cutoff value of historical grade of steatosis was arbitrary and not significantly associated with clinical outcomes. Usually, the percentage value of MRI PDF the percentage value of historical grade of steatosis is usually 2 to 3 times higher compared to the percentage value of MRI PDFF. And so it is important to differentiate the values of histological grade and the MRI PDFF. MR spectroscopy is the most direct MR-based method to calculate PDFF. MR spectroscopy depicts proton signals as a function of their resonance frequency. On MR spectroscopy, the center frequency of peak is described in ppm with respect to a reference molecule. As shown in this figure, the resonance frequency corresponding to proton in water and to the dominant proton in fat are distinct. So the signal from water and fat can be identified and quantified, and fat fraction can be calculated. However, MR spectroscopy-based PDFF can be challenging for several reasons. First, sampling error may present owing to its limited spatial coverage, which can be problematic in patients with uneven hepatic steatosis and for longitudinal studies. Furthermore, MR spectroscopy is limited by its complexity and operator and device dependency. When you compare MR spectroscopy PDFF and MRI PDFF, MR spectroscopy directly measures fat, whereas MRI indirectly measures fat. Compared to SPDFF, MRI PDFF has a potential advantage of its large sample volume that might better represent the degree of hepatic steatosis. After all, MRS PDFF and MRI PDFF has a nearly perfect agreement, and both are widely accepted non-invasive methods for evaluating hepatic steatosis. But recently, MRI PDFF is considered to be more precise than liver biopsy for therapy monitoring in patients with NASH and use it as a secondary endpoint in clinical trials. Complex-based, as I mentioned, complex-based approaches require additional licensing, so magnitude-based approaches are often used in clinical trials. And then let's move on to ion quantification. The most prominent effect of ion in increasing I2 and I2 star relaxation rates. As the degree of ion overload increases, the T2 and T2 star will decrease. So the affected organs show low signal intensity on T2 and T2 star weighted imaging. You can see the liver show the low signal intensity on T2 and T2 star weighted images, and as the liver ion concentration increase, the signal intensity of the liver decrease. The degree of signal decrease is more higher on T2 star weighted images. There are several ion quantification methods using MRI. In this talk, I handle two major techniques, signal intensity ratio method and relaxometry methods. Unlike PDFF, which can be calculated directly using signal intensity, ion quantification requires a calibration process between the actual measured liver ion concentration value and the MRI measured value. I'll start with R2 relaxometry. R2 relaxometry is a well-validated measure known as VSAR, and it adopts Chang's method. It is commercially available and only FDA-approved technique for 1.5 Tesla scanner. To calculate R2 value, it requires 5 T2-weighted spin equation during free breathing with increasing TEs. R2 relaxometry shows the excellent correlation within a wide range of liver ion concentrations, reproducible across different scanners, and often determined as the gold standard. But it requires a long imaging execution time, nearly up to 20 minutes, and complex data processing with centralized data analysis. So it takes 2 business days to get the result. Our service fee is attached to each patient. The VSAR is recently available for 3 Tesla scanners, but has not to be fully validated. R2 star relaxometry is an emerging reliable method. Unlike VSAR show a nonlinear correlation with the liver ion concentration, R2 star relaxometry provides a linear correlation. It can be calculated by multiple single echo GRE or single multi-echo GRE. PDFF and R2 star relaxometry is simultaneously estimated by acquiring multiple echoes to correct T2 star decay. To capture the rapid signal decay in severe ion overload, the first echo and interval among TEs should be as short as possible. It has advantages such as fast execution time, and unlike VSAR, there are several freely available quantification softwares, but it has major drawbacks. Estimated liver ion concentration values differ according to the execution setting and fitting algorithms, and it leads to inaccurate quantification in massive ion overload due to difficulty in capture extremely rapid signal decay. The last one is signal intensity ratio technique. It measures signal intensity ratio between the river and unaffected organ, usually paraspinal muscles. This SIR method generates 5 GRE sequences during separate pressure holds with the following execution settings. As a result, 5 different weighted images were generated. It is widely available simplistic method. Oh, wait a minute. It doesn't work again. As a result, 5 different weighted images were generated. It is a widely available simplest method. It should be performed using the body coil only to avoid the signal gradient between the surface to the depth. Signals were measured using 3 RYs in the river and 2 RYs in paraspinal muscles, and these measurements repeated in previously noted 5 MR imaging sequences. It has benefit in terms of simplicity and generalizability, but has a major drawback such as least accuracy and low SNR. SIR technique is least accurate than relaxometry methods. Both methods have their advantages and disadvantages, but recently, the relaxometry methods has been favored over the SIR method. R2-star relaxometry is preferred because it is a very wide range of the scanner and simultaneously acquired with the PDFF. And R2 relaxometry has an advantage in its accuracy. But important thing is that no matter which relaxometry you use, you keep the same method for diagnosing and follow up with your patients. Recent studies have shown that the MRI-based R2-star mapping enable the reproducible quantification of river ion overload across 4 centers, 3 vendors, and 3 field strengths. On the basis of the available literature and the collective expertise of this consensus panel, compound corrected R2-star based river ion concentration is the most practical method with the strongest level of evidence for accurate and reproducible quantification of river ion concentration. So we briefly reviewed the MR quantification method in quantification and river fat and iron. It's time to wrap up my talk. Early detection and river fat and iron is very important to prevent its progression into more advanced stage, including cirrhosis and hepatocellular carcinoma. MR quantification is very accurate, reproducible, and non-invasive measure of river fat and iron, and is effective in diagnosis and evaluating response to treatment. MR quantification, among the MR fat quantification, MRI-PDFF is near the gold standard for fat quantification. And MRI-PDFF can be calculated directly from the signal ratio of fat and water after correcting confounders. For the MRI quantification, different river concentration values according to the technique and calibration method are present, and the keeping the same method in diagnosis and monitoring is very important for your patients. I would like to thank Professor Jessica for sharing a lot of materials with me, and thank you for your attention.